and I'm an epidemiologist at KDPH, and I cover Zika surveillance, and I'm the Kentucky coordinator of our participation in the U.S. Zika pregnancy registry. So I'm going to talk about both of those things today. I actually brought a couple of handouts, so. You don't need these to understand the presentation. They're just, I think they're some of CDC's great handiwork. CDC's website has tons of handouts for the public, for healthcare providers, all sorts of audiences that have a lot of good information that's very digestible. Because we, like Jessica said, there's a lot of Zika in the media, and people really need to have a good understanding. So that resource has a variety of audiences that the materials are geared towards. So today I'm going to talk about, just give kind of an overview of Zika, talk about how testing occurs in Kentucky and what follow-up is like, and then introduce the U.S. Zika Pregnancy Registry. So Zika is a single-stranded RNA virus that's closely related to, can you guys hear me? Okay. I might move forward a little bit. Is that a problem, Mary?
I can move.
Okay, Zika is a single-stranded RNA virus that's closely related to some other viruses, dengue, yellow fever, Japanese encephalitis, West Nile. It was first discovered about 70 years ago in Uganda in a non-human primate, and then about a year later in a mosquito, and has been kind of at a normal level. Nothing really, it was just mild illness was associated with Zika infection before, the past couple of years. It's an arthropod-borne virus, or an arbovirus. It's primarily transmitted by the bite of an infected Aedes species mosquito. So the clinical presentation of Zika is unspecific, and many people don't have symptoms at all. The most common symptoms are fever, rash, joint pain, especially around the wrists and ankles, and conjunctivitis. Other symptoms include muscle pain and headache. These symptoms typically last about 3 to 7 days, and patients are typically viremic several days before the onset of symptoms until about a week after. And I mentioned that several people don't have any symptoms. People are still viremic even if they're asymptomatic. So, as you're probably aware, there's no vaccine for Zika. There's no specific antiviral treatment. The treatment is treating the symptoms. So rest, drinking liquids, taking medicine, not going to use the later. Aspirin and non-steroidal anti-inflammatory drugs like ibuprofen should be avoided because, like I said, it's closely related to dengue, and dengue hemorrhagic fever, which can happen when you have dengue. It's not a good idea to be taking non-steroidal anti-inflammatory drugs for that. That's sort of a different presentation. So, Zika can be transmitted in a number of ways. A bite from an infected mosquito, sexual transmission from any partner, maternal to fetal transmission, laboratory exposure. Blood transfusion is possible, but it hasn't been recorded at this time. I have a whole list of ways that there's no evidence that it's transmitted. Those include touching, coughing, sneezing, saliva, or breastfeeding. In fact, CDC recommends that babies born to positive moms still breastfeed because the benefits outweigh the risks. So we're going to talk a little bit more about mosquitoes, but I won't steal Clay's thunder. Zika virus is spread through the bite of an infected Aedes aegypti or Aedes albopictus mosquito. Aedes albopictus are the primary mosquito that we have here, and Aedes aegypti we have those here as well, but they're the primary vector of Zika, dengue, and chikungunya. These mosquitoes bite during the daytime and early evening, so we have the fight the bite day and night. They prefer to lay eggs in containers of standing water, tires in your yard, flower pots. that sort of thing, and they stay lower to the ground, so less than 10 feet. These are kind of the mosquitoes that are hopping around the bushes in your yard, not the ones that you see up in the trees. So Zika can be passed through sex from male to female, male to male, female to male, possible female to female, but that hasn't been documented. So transmission is most common from male to female. And this is any sort of sexual exposure, oral, anal, or vaginal sex without a condom from a person who traveled to or lives in an area with Zika. We don't know how commonly Zika is transmitted sexually or what the duration of transmissibility is. Zika can be passed through sex before symptoms start, during symptoms, and after they're over. And also, if a person is asymptomatic, they can still spread Zika. Okay. Zika virus can pass from a pregnant woman to her fetus during pregnancy or around the time of birth. We don't know how often this happens. Infection during pregnancy is a cause of microcephaly and severe brain defects, and is also linked to other problems such as miscarriage, stillbirth, and birth defects. Just because Zika causes some birth defects doesn't mean that everybody who gets Zika is going to have these effects. There's no evidence that pregnant women are more susceptible to Zika, and there's no evidence that the clinical course of infection is any different in pregnant women than non-pregnant people. But because of this, threat to pregnant women and their babies, CDC is obviously very interested in studying this further. What are the findings? Clinical findings observed in affected infants. The big one you've probably heard about is microcephaly, and you can see in this picture that this is a baby with severe microcephaly. The dotted line shows the normal head size for a baby of that sex and age. So congenital Zika syndrome is associated with a number of anomalies. You can see severe microcephaly here, as well as thin cerebral cortices, eye anomalies, congenital contractures, and early hypertonia. And if you're interested in this, there are lots of resources, CDC resources about this. So, like I said, before 2015, Zika was found in Africa, Southeast Asia, and the Pacific Islands, but was only associated with mild clinical illness before an outbreak in the French Polynesian Islands in 2013 and 14, and then Brazil and all that has followed there. So CDC's website provides a lot of information about where Zika is being transmitted. If you just Google CDC location, this will pop up. There are two websites. Maybe I'm going to talk about this. Okay. There's one that shows all of the places where active transmission is occurring, and these are the places where we're concerned about kind of ongoing raised levels of transmission. These would include a lot of the areas in Central and South America, the Caribbean, Puerto Rico, but there's also areas of the world where Zika is transmitted, especially in Africa, where there's endemic transmission. That means it's going on, but it's kind of a normal level of it going on. So if you have someone who's traveling there, they may be exposed, but the threat is a lot less risky there versus somewhere where there's ongoing sort of active epidemic style transmission. But this website has a US map with case counts. It has a world map. You can see that the United States is orange. To date, only two kind of small geographically confined areas of the US have experienced local transmission in Texas and in Florida. So when you see like all of South America, that doesn't mean that every single part of South America is experiencing local transmission, but it has been reported in that country. Okay, so the best way to prevent Zika is to prevent mosquito bites using an Environmental Protection Agency registered insect repellent with one of these key ingredients, and heeding any warnings about what age it should be used, what kind of appropriate uses of that. Wearing long sleeve shirt and long pants, staying in places with air conditioning or window and door screens, and removing standing water around your home to get rid of mosquito breeding sites. There are also recommendations for preventing sexual transmission. Pregnant women and their partners are encouraged to use condoms for the duration of the pregnancy, and this recommendation stays even if one or both of them test negative. Couples who are trying to become pregnant are encouraged to wait at least 6 months to attempt conception. And then non-pregnant individuals, if you're asymptomatic, women are encouraged to wait 8 weeks, and men are encouraged to wait 6 months from their travel, and if they are symptomatic, it would be those same time frames based on their symptom onset. Now, if a woman and a man travel, obviously we're going to go for the longer timeline. So, again, returning travelers can spread the virus through mosquito bites or through sex, and so travelers are encouraged to use insect repellent during their travel, but also 3 weeks after return, so that it prevents it from getting into the local mosquitoes. There's a publication in Emerging Infectious Diseases, which is a CDC publication that's reporting a much longer detection of viral RNA in whole blood, and so that may be extended, but for now CDC's recommendation is 3 weeks. And then again, heeding the sexual transmission guidelines. CDC has some really great resources for travelers. The first one is a phone number specific for Zika, and you text that phone number and say where you're going, and it texts you back and can periodically give you updates of the threat, which is really neat. The Travel mobile app is an app that is not just for Zika. You just put in where you're going, and it has all sorts of CDC recommendations for travelers, which is very handy. Okay, so I kind of wanted to just give you guys probably the information that you have heard before as setting the stage as we talk about surveillance and the registry. So here's a map. This is straight from CDC's website that shows case counts in the U.S. And these are cases that have been reported through ArboNet, which is how it's the surveillance system that CDC is using to pull the data for these maps. So far in the U.S., there have been 5,139 cases reported. Most of those, 94%, have been travel-related. We also have local transmission, and then other, including sexual transmission, congenital infections, and other transmission. 1,534 women have had lab evidence of Zika infection, and of those, 1,143 have completed pregnancy. So we have information about the births. There are people who are still pregnant, obviously. Of those completed pregnancies, 47 live-born infants have had birth defects and 5 pregnancy losses. That should not say birth defects. It should just say pregnancy losses. Sorry. The preliminary data from the pregnancy registry shows about 6% of births are having some effect. That's very preliminary data, so don't go telling patients that's the thing. The Brazilian case studies, I think it was like between 1 and 13%, which is also a pretty wide range. So in Kentucky, we've had 36 cases of Zika. All the adults have been either travelers or have had sexual exposure to a traveler. Because of that, we don't suspect any local transmission through mosquitoes. We've had most of our patients, 34 of them have been symptomatic, and that means 33 of them have had a rash. So we've got patients who are pretty clearly following the symptoms that are associated with Zika. So we've got a lot of people are having rash, fever, arthralgia, which is the joint pain, and conjunctivitis. Less than 5 of our 36 cases, less than 5 of those are pregnant women. So now I'm going to talk about the process for testing and follow-up, what that looks like in our state. So you don't have this handout, but it's straight from CDC, and I'm going to go through this kind of step-by-step, what happens. The need for testing is determined, then the health department is contacted, specimens are, samples are collected, shipped, and tested, and then we get the results. So, yeah, you guys don't have this handout, but we're going to go through it pretty specifically. So step one, the need for testing is determined. Healthcare providers should know the clinical manifestation of Zika and should be able to assess their patients for risk factors. The patients that we're really concerned about are patients who are planning to conceive, pregnant women, and anybody who's traveling, old or young, pregnant or not. These are the people who we need to be thinking about for Zika. CDC has some really great resources, not to sound like a broken record, but these are some pretty neat widgets which are interactive. You can kind of click through them. There's a topic of the week widget, a know your risk Zika widget, and then there's also a pregnancy and Zika testing widget, and that's really helpful for healthcare providers who are dealing with pregnant women. It can help determine a need for testing, but also help you interpret the test results and think about next steps. So, we've determined the need. We've identified a patient who needs to be tested. Now we're going to contact the health department. The healthcare providers who are doing this will complete an exposure form that gathers demographic information about pregnancy, travel, other exposures, and send that to the regional epidemiologist and the patient's county of residence. That's probably Abby or Jessica. If you don't know who that is, Abby or Jessica could tell you who that is, or could send it to them for you. This is requests for maternal and infant testing at the time of delivery should come straight to KDPH. We're dealing with the infants at the state health department, and so if mom didn't have prenatal care or wasn't screened or it just didn't come up, and testing is being requested at the time of delivery, that does. So who gets approved for testing? We pretty much follow CDC's criteria for this, their algorithm. Pregnant women with at least one of these things being true. Pregnant women who are symptomatic with at least 2 of the key symptoms. Pregnant women with a history of travel, who have traveled within the past 12 weeks or within 8 weeks of conception. Pregnant women who have had a sexual exposure within the past 6 months to someone who has traveled. Or if ultrasounds indicate fetal abnormalities. We're going to be testing, and the mom has traveled or has a sexual exposure to someone who has traveled. So non-pregnant individuals, we're testing symptomatic non-pregnant individuals. So if they're symptomatic and they have an epi-link, which means they either traveled or they have sexual exposure to someone who traveled. And finally, babies. So like I said, baby approvals for infant testing are coming through the state health department. And we're testing babies who are born to pregnant moms and babies who have abnormalities and there's a maternal link to either travel or sexual exposure. So then what happens? So the regional epidemiologist gathers the information and assesses the situation and makes a determination about whether testing is appropriate or not. She or he will provide an approval number and walk through the steps of how that is submitted to the state lab. Talk about the type of test that's appropriate, and make sure that education is provided to the patient. So all patients should be advised to participate in mosquito control activities and wear insect repellent after travel. We've talked about the guidelines for the recommendations for prevention of sexual transmission. And then pregnant women and their partners, as well as anyone who's considering becoming pregnant, should be avoiding travel to one of these areas. So, you've gotten an approval. Now the samples are collected and shipped. The state public health lab has, this is the link to their website. They have a form that shows instructions for collection and shipping of specimens that goes through the approvals, the collection, packaging, and shipping. And for both molecular and serologic testing, urine and serum is requested. So then the samples are tested. So we do testing at the state public health lab for this first, the molecular method, the PCR testing, and we also do testing by IgM at the state lab. PRNT is confirmatory testing that is conducted at CDC. right now there are no actually approved Zika tests. These tests are functioning under an FDA emergency use authorization that is because there's a public health emergency. That's how these tests got into use. Okay, and I think I said this. Results for Zika are typically available within a week if everything is performed at the state lab. So I'm not going to talk too much about the difference in the tests, but I do want to point out that the PCR test detects viral RNA and body fluids. We do this for serum and urine, and this tests for chikungunya, dengue, and Zika. So if there's a positive PCR for Zika, we know it's Zika. And in fact, that is what is going to involve an environmental response. A positive IgM is presumptive detection of anti-Zika IgM antibodies, and this is going to require confirmatory testing at CDC. Like I said, these tests are more sensitive to having a past infection of dengue maybe, or being vaccinated for yellow fever. There may be some cross-reaction. So this is just kind of a nice visual of the timeline for detecting viral RNA and then the antibodies in patients. So we use PCR testing within 2 weeks of symptom onset because that's really when it's best detected, and then the IgM testing 2 to 12 weeks after symptom onset or last possible exposure. And that could be sexual exposure or travel. Okay, and so then the state lab will send the results to the submitting or ordering provider. If a healthcare provider doesn't have a copy of the results, that person can contact Jessica or Abby to get a copy of the results. Tests performed at commercial labs that have positive results should be reported. Both the lab and the provider should be reporting them because it's in the reg, and Zika is a nationally notifiable condition. And then healthcare providers are responsible for informing the patients. They can lean heavily on regional EPIs. They can call us at the state if they've got questions about how to interpret the results, education, or strategies for preventing transmission. Okay. Here are the possible results indicating laboratory evidence of Zika. The testing algorithm and interpretation is kind of complicated, but basically we're looking for positive PCR or positive IgM followed by elevated levels for Zika and dengue in the PRNT. Okay, so what happens? What do we do if we don't have evidence of Zika or another flavivirus? That person is just encouraged to follow recommendations from CDC about preventing transmission as they were when they first got tested. This is a question that we get from a lot of people, like, so I'm negative. We still have to wear condoms for the rest of the pregnancy? Like, that's still CDC's recommendation. Or like, I'm negative. Do I really need to wear bug spray? That's still CDC's recommendation because post-travel precautions are really important to protect the health of other Kentuckians. Follow-up for non-pregnant patients and pregnant patients is pretty similar. For non-pregnant patients, the regional EPIs do the follow-up, and for pregnant patients, we at KDPH do the follow-up. The case is reported to CDC the same way through the National Electronic Disease Surveillance System and ARBONET, and the same thing happens if the patient is PCR during mosquito season. I think Clay's going to talk to you guys about what the environmental health follow-up will look like. And then for pregnant patients, the patient is enrolled in the U.S. Zika Pregnancy Registry, which I'm going to talk about now. Did you guys know about the registry before coming to this meeting? Okay, good. Awesome. Okay. So CDC has funded 45 jurisdictions to do additional surveillance looking into how Zika virus infection affects pregnant women and their infants. So the purpose is to learn more about effects of Zika during pregnancy and to learn about the growth and development of infants born to Zika positive moms. This data will be used to update recommendations for clinical care to help make better decisions about how to prevent transmission and exposure, and to plan services for pregnant women and their families. You can get into the pregnancy registry two ways. Pregnant women and their babies, or mother-baby pairs, are enrolled into the pregnancy registry. So a positive mom and her baby, or a positive baby and her mom. Those are kind of the two ways to be included in the registry. We have three primary data collection tools. We collect data on maternal health history. We do neonatal assessment and infant follow-up at 2, 6, and 12 months. I work in the Division of Epidemiology and Health Planning, and we are working with our partners in the Division of Maternal and Child Health to do this. So we follow the moms and the babies through birth, and then they kind of take over with the infant follow-up. We coordinate Zika testing, ensure data collection and reporting that to CDC, providing guidance and support to healthcare providers in birthing hospitals, and making sure that these babies are referred to specialty care, especially the Commission for Children with Special Healthcare Needs. Okay, this is the last slide. Everyone's head perked up? I don't blame you. Okay, so what happens when a pregnant woman has evidence of Zika? What do we do in Kentucky? Well, we do the things I described earlier. We enter the case into the surveillance systems. I contact the obstetrician. If they're PCR positive, we coordinate with the local health department to take environmental health actions in the patients enrolled in the registry. So what we do is we arrange a conference call with the hospital. Usually we do that through the infection control person that we've been in contact with. We discuss clinical and laboratory evidence. Usually somebody from mother baby is there, labor and delivery, maybe the OB. And infection control, we've got someone from the state lab, and kind of go over what exactly is included in the physical evaluation. What are we looking for in terms of specimens for lab evaluation? Then the baby's born, laboratory testing is performed. Usually this can be done exclusively at the state public health lab. Only some situations will call for additional testing at CDC. And then we get the information about the clinical and laboratory evaluation and provide a recommendation to the pediatrician on clinical care and follow-up for that baby. I said that was the last slide, but this one's no content really. CDC Key Messages is a sort of publication that CDC updates every 2 weeks. You can just Google CDC Zika virus key messages. It's very readable. If you have a question, it's probably going to be answered in there, and it's something that, like my brother, who knows nothing about health, is in a totally different field, could just read it and it would be approachable. There are also a number of slide sets, CDC Zika 101 slides, the clinician outreach and communication activity. There are tons of slides and webinars for that, directed at healthcare providers, infection control, nurses, pediatricians, and then this is just updated guidance for the different preconception counseling, lab testing, lab interpretation. So these are the references for my slides. This is my contact information, and you can also get that from Jessica if you have follow-up questions. I know I went through that very quickly. Do you guys have questions about Zika, about the registry?